because it's in different time zones and we really appreciate your being here virtually, I will take this opportunity to welcome us all back for our last session for today, which is about COVID-19 in Bangladesh, Pakistan, and Nepal. Two countries that we've already begun to speak about earlier in the day. And this is a hybrid panel in which we will have no, actually, right, exactly, sorry. Two people virtually and one of our panelists in person. And so I'm going to actually introduce the panel as a whole right now, and then we'll go from speaker to speaker. So first on, we have Professor Mushfiq Mubarak, who is a professor of economics at Yale University with appointments also in the School of Management and the Department of Economics. He's the founder and faculty director of the Yale Research on Innovation and Scale, and holds a range of other appointments, including at JPAL and IGE at LSE. So I have read Professor Mubarak's work, as I'm sure many of you have, in particular around questions of innovations for poverty, social development, public health, and he has been involved in a number of policy initiatives, including collaborations with the government of Bangladesh, civil society and think tank organizations such as BRAC and others, and has been, I thought, doing an admirable job of really getting a lot of his work out in a range of media outlets such that it becomes publicly accessible. So we'll begin with Professor Mubarak for about 15-20 minutes, followed by Professor Asim Khwaja. Hi, Asim. Who I knew from my time at Harvard and who again needs no introduction. For anyone who is interested in questions of social welfare, poverty, public goods provision, questions also of ethnicity, collective action. Professor Khwaja has been a kind of leader in that field for many years. He's the director of the Center for International Development at Harvard, also for the Sumitomo Foundation for Advanced Studies on International Development, and all at the Harvard Kennedy School, and is co-founder of the Center for Economic Research in Pakistan, which is an incredible, wonderful initiative. And for those of you who are not yet aware of it, I very much encourage you to check it out. And is published, of course, in all the top economics journals, as well as, again, a number of popular media outlets. And so, Professor Khwaja will be in a way following up on many of the remarks that we heard on that in that lunchtime plenary session on COVID earlier today. And finally, we have in person Dr. Ramu Kharel, who's a global emergency medicine fellow and a real doctor. I made the mistake very early on after getting my PhD of writing my name. It's Dr. Prerna Singh in an airplane reservation. And of course, it was the time when there was a medical emergency. And I was told by we call them Air India hostess aunties. They're the Air India hostesses, but they're really aunties. And I got publicly humiliated by an auntie who told me that you're not a real doctor. So Ramu is a real doctor. He's a global emergency medicine fellow here at Brown. And he has a focus in particular on health system strengthening and emergency system strengthening in rural settings, and has worked a lot around questions of disaster and in rebuilding health centers, in particular after the Nepal earthquake, through civil society organizations. And if you're ever in trouble, he currently practices emergency medicine here in Providence, Rhode Island. So we'll turn it over to the panel. Professor Mubarak, we'll begin with you for about 15-20 minutes, followed by Asim and Ramu.
Thanks very much for the invitation, and it's an honor to be on the same panel as Asim and Ramu. And thank you, Ashu, for putting all of this together, and for the rest of the faculty and staff at Brown as well. And I love the story about the real doctor in a story about the real doctor. So I'm going to, the way I interpret it, and I'll tell you why. So the way I interpreted the panel when it said Bangladesh, Nepal, Pakistan, so basically all of non-India in the same panel. I was like, oh, let me talk about this one project that's actually running in all those countries, but also in India, but I won't talk about that because we've had a lot more time on India in the conference. So I'll talk about this one project on masks, which is actually now running in all three countries, and I'll share my screen to show you some slides. And yeah, so I'm traveling actually. I'm in Europe at the moment, in Luxembourg, and so I've been on planes recently. And I have been, unlike Prerna, I've been making a point to put my name as Dr. Mubarak, because I feel like if there's some issue on the airplane where somebody's not wearing a mask and the air hostess is asking them to put it on, And then they ask, is there a doctor in the house? I would like put my hand up and say, look, I know about masks. This is my one chance to be the real doctor. Okay, so this is a project that was started as a randomized control trial done by there's an economics and behavior component to it, which is led by economists at Yale, and then there's a serious epidemiology component to it as well, which is led by epidemiologists at Stanford Medical School. Innovations in Poverty Action was implementing the trial, but then since then we've been scaling the program up across multiple countries, and so a lot of other partners have come on board. So BRAC, which is a very large and impressive NGO in Bangladesh, and then our primary partner in Pakistan is the Lahore University of Management Sciences, along with the City Commissioner's Office in Lahore. And then some extension now also with the health minister in the Khyber Pakhtunkhwa province. And then in India, SEWA, CSPC, JPAL have been partners. And in Nepal, actually, I should have their logo up here as well. There is a RAT, the Rapid Action Task Force, convened by the Nepali government, and they're our key partners. And so why are we talking about masks? Because in South Asia, we're still ways off from getting anywhere close to universal vaccination. And until that happens, like, we need other ways to stem the spread of COVID such that we don't get the same kind of crises that we saw in India just about 3-4 months ago. And so in order to generate some evidence on this, we conducted a cluster randomized control trial. A cluster because, like, entire communities, say every single household in a village, plus the mosque that serves the village, the market that serves the village, they acted as sort of a treatment unit, right? And then we chose control units that were physically separated. And this was a somewhat unusually large scale trial. We collected data from over 340,000 adults across 600 villages. And we tested, there was, true equipoise at the outset as to what types of masks would work best. So we tested in different villages, surgical versus cloth masks. And you should think about the project as having two big stages. So first stage is, how do we get people to wear masks, right? And the second stage is, once you get people to wear masks, does that actually reduce COVID transmission? Okay? So that second stage required the very large scale trial. And the reason is, when we did power calculations, given the low prevalence of COVID at the time in rural Bangladesh, right? You need large samples in order to be able to detect statistically significant changes in a rare outcome. So that means that we were massively overpowered for the first stage, right? On the question of, like, how do we get people to wear masks? So that meant that we had the luxury of doing, say, a 20-arm trial rather than a 2-arm trial. So rather than just like treatment control, we tried out a plethora of strategies to see what would be successful in getting people to wear masks, right? So the first thing I'll talk to you about is, out of those 20 strategies, it turns out there's a precise combination of 4 things if you do that well, that leads to like a significant increase in mask usage, more than a tripling of mask usage, and the effects are persistent. And that 4 things, and the 4 things is why we call it norm, because we think it's changing social norms. So the first is free mass distribution, which is a no cost, and we deliver masks door to door. And when you do, we also provide information on why it's important to wear masks. So the Prime Minister of the country, Sheikh Hasina, the director of the Imam Training Academy, and perhaps most importantly, Shakib Al Hassan, the best cricketer we've ever produced. So they kindly recorded, videos for us. So we made a little, like, information thing that was shown to all households. And then beyond this, like, it was really important to do a secondary distribution of the mosque, because this is an environment where people are standing shoulder to shoulder and it has high transmission risk. And that also gave us the opportunity to work with the imam and get him to endorse the concept, right? And we even, prepared a script. So during the khutbah, he could share some information as to why they were partnering with us. But we also, not only the imam, we also work with, like, the school headmasters, or say a union parishad chairman who might be living in the village, right? Or people who are like elders who others would listen to. And we wanted to make sure this is the modeling part, the kind of the role model in the village sort of worked with us and endorsed us. And then we also did, like, some miking and secondary distribution and markets. Yeah. So we did all this, and given the large sample size, we could do iterative experimentation. So we tried all of this, and we found increases in mask wearing, but at rates that we were disappointed by, because we needed significant changes in mask wearing such that we could track COVID transmission changes, right? So then we added something else, which is like, you can't just distribute masks on day one and leave the village. Like, you have to periodically go back and remind people, right? So we hired these mask promoters locally wherever possible to like kind of politely intercept people if somebody was not wearing a mask, to say, look, we distributed masks everywhere in the village, why don't you have yours on, right? Can you please put it on? Or if he forgot it, can you go back home and get it? Or if that's inconvenient, he'd have a mask in his hand to give it to people, but say, look, don't forget it next time because we don't have too many of these, right? So we did this for a few weeks, like started at 3 times a week, then twice a week, then once a week, sort of slowly scale down. So once you do these 4 things together, right, the experimental result is that in control areas, you have 13% of people wearing masks properly, like covering nose and mouth, and that goes to 42%. And importantly, this effect is sustained for 10 weeks, including a period after the intervention ends. So this is what the data looks like, right? So it wasn't just a novelty factor, right? And the way we did this was like, there was a separate team from a different institution that was passively, like with smartphones, we just hired a bunch of people who would passively observe what's going on in the village. So imagine like somebody sitting in a tea stall for a couple of hours, and every time people are walking by, like just noting down what's happening. Are they wearing a mask? Is it a project mask? Or is it just like nothing at all, or like putting a dupatta over their face? Are they wearing the mask properly? But also, are they social distancing, right? And so that's how we collected this data. And we see that like the mask wearing remains pretty consistent. And these last 2 data points on the right, those are for a period after we ended all intervention activities. Right? And the other thing here, why did we measure physical distancing? It's because at the outset, in order to get the, make the donors comfortable about this project, we had conversations with, say, the World Health Organization chief scientists, right, to try and figure out exactly why they weren't vociferous in promoting masks and what they needed to change their stance. And one of the things they worried about explicitly with us is that, look, we don't have any randomized control trial-based evidence that masks work. And what if it just gives people a false sense of security and they stop doing other things like social distancing, right? And so what we actually find is that when you do the mask promotion, there is no such moral hazard. If anything, it actually increases physical distancing. Like, people just take everything more seriously, right? And then the other thing we learned is, I won't get into the details of it unless there are questions about it, is that at the outset, we were unsure which mask would work. The experts locally told us surgical masks would not work because people think of it as one-time use. But through the course of this project, our research team has become huge fans of surgical masks, right? So that's what we're now promoting. We've sent such masks to India, to Pakistan, to Nepal. But then we've also gotten large donations of cloth masks, which we're also sending to all 4 countries. Okay, so there's I won't spend too much time on this, but there's a whole bunch of other things we tried. I told you it was a 20-arm trial, right? There were things that were sensible to try at the outset, like for example, psychologists tell us that if you get people to make a verbal commitment, they're more likely to follow through. So we tried that. Other research tells us about text message reminders or providing incentives, or like this comes from social rewards. This comes from like in India, the open defecation free village type idea, right? So we tried all of this. A lot of this just didn't produce anything for us, including like trying to threaten people with actual sanctions involving the police. That also didn't do much. So okay, so that's the first stage, how to get people to wear masks. And let me just tell you about the second stage, which is essentially it's important to recognize that we are able to track only symptomatic seropositivity, so symptomatic transmission. We are not able to track asymptomatic transmission, okay? And the reason is we first go and ask all 342,000 people whether they had COVID symptoms, like WHO defined COVID symptoms. If they had symptoms, then we prioritize them for blood sample collection and then do seroprevalence study. So that means it's only people who are symptomatic would be able to get. And so what you see is in symptom reporting, there's about a 12% reduction overall. This is aggregating across cloth and surgical masks. And then in terms of symptomatic seropositivity, there's about a 9.3% reduction overall, right? The actual numbers, so the actual numbers here are not so meaningful. I can explain offline why that is, because of the way that we're constructing the denominator. It's really the relative reduction that you should pay attention to, the 12 and the 9. Okay. Now, in the surgical mask villages, actually the effect is larger, right? compared to the cloth mass villages. And in particular, in surgical mass villages, when you look at, so this was pre-specified, like that we wanted to look across different age groups in our pre-registration. And what you see is that for the population older than 60, we are able to eliminate about 35% of symptomatic seropositivity, of symptomatic infections. In the most vulnerable population, in between 50 and 60, it's about a 23% reduction. And then younger than that, we don't see anything. And the reason we don't see anything, here's something I'm gonna talk beyond the experimental result. I'm just giving you my interpretation, is that since we are not able to track asymptomatic transmission, we are very likely to miss, the people who are young, right? Because a lot of that COVID is asymptomatic. All right, so now let me end by just talking a little bit about our partners in various countries. So these are the various countries in which we're working. India, Pakistan, Nepal, Bangladesh are our primary targets, but also now, Mexico, Uruguay, and we just started in Sierra Leone and Ethiopia as well. So what's happening in India, the main partner is SEWA, Self-Employed Women's Association, based out of Ahmedabad in Gujarat. So they move really, really quickly. They were the first ones to take the project and implement across all the villages where SEWA works. So they started in Gujarat, but they moved to Rajasthan, UP, etc. Now in India, we tried very hard. I spent a lot of time with state governments, including, like, say, in West Bengal, it went to the chief minister's office, but ultimately the budget wasn't released to procure tons of masks, right? I even got donations from the US, but India refused to let the masks in because they wanted local production. But we had a catch-22, which is you want local production, but nobody actually has the money to buy it, whereas there are free masks coming from outside and you don't want it, right? In Bangladesh, we ultimately had the biggest success, which is after talking to the Ministry of Health, the Director General of Health. So they gave us, along with BRAC, the responsibility of covering about half the country. So we picked it's actually 37 districts where the positivity rates were high. So the BRAC was able to implement the model with pretty high fidelity to the research to cover in this area of 81 million people, right? And then in Pakistan, the big champion was the city commissioner of Lahore, a bureaucrat rather than a politician. And then one particular partner, actually one of Asim's former advisees and students named Maha Rehman, she's just been like a superstar. She's been really fantastic in forming all the right connections, and she had, by virtue of working on reporting numbers, COVID numbers throughout the pandemic, she had attained a lot of credibility, and we really were able to take advantage of that. And I'm happy to say, Asim, that every single household in Lahore has now received an envelope with the Yale logo on it, right? And as well as Stanford and IPA. But yeah, I just wanted to make sure to point that out. And these are just pictures. So basically, so some of the innovations that came up, without taking too much time, is that in Bangladesh in rural areas we did door-to-door mass distribution, right? In Pakistan, we ended up using the Pakistan Post. So this is an envelope that actually got sent with a mask and some information, etc. So we were trying to figure out, okay, how do we, in a city setting, right? How do we adapt the rural model, right, to something that actually makes sense of the urban area and do it a lot more cost effectively? And then one other thing I want to just leave you with quickly, I know I'm running out of time, is that we are, the same research team, now that we feel like, we came up with a model for masking that seems to have really resonated with people, right? We are trying to now develop that exact same sort of model to make the last mile delivery of vaccinations more effective. So right now there are supply constraints in all these countries, right? But at some point when the supply constraint is alleviated, we will need to make sure to get back jabs in people's arms quickly and effectively. And we're trying to develop the model for doing so, and using the same types of techniques of randomized control trials. Not a randomized control trial of vaccine efficacy, but the randomized control trial on how to persuade people to take the vaccines. All right. And then, I should say something about Nepal, and I'll stop. So we're working through the Rapid Action Task Force, and we were able to get a lot of the US donated masks into Nepal. and we picked like 3 places to do pilots. So these are the 3 places: an urban area, a rural area, and then kind of a semi-urban but flood-affected region, with the goal of like just to learn how to do this and then scale this up nationwide. We've procured enough masks, like 30 million masks, to be able to cover all of Nepal. And some of the other innovations that came up is, it just so happened my high school friend, I went to school in India and there was a Nepali student there. His brother-in-law happens to be the most famous cricketer from Nepal for us. So he's been a big champion, and the Nepalis in the audience probably recognize these other celebrities better than I would, right? But we've been like innovating there in different ways, and also Miss Universe Nepal or Miss World Nepal, or she's been a great champion as well. Okay, so let me just stop. So now the other thing we're doing is, like, while our focus really is on South Asia, right? It's now we're hoping that to change the conversation around masking in other countries as well, including the United States. There's been a lot of insane takes on our results. So a lot of what's kept me busy for the last few weeks is just fighting with both, not just me, but Jason, my co-author from Yale, fighting with both the right wing as well as the left wing in some of the really strange interpretations they've had about this study. It's a really strange reaction to a randomized control trial where people seem to be really passionate about what the study shows or doesn't show. All right, I'll stop there. Thank you.
Thank you so much for that. I mean, I have so many questions, and just, you kind of took it away in terms of both the kind of breadth and also the richness of your presentation. But I'm going to hold off on all my questions and just turn it over to you, Asim, for about 15, 20 minutes.
Great. I'll take less time. I'll just go very quickly because I think it'll be fun to open up a discussion. And since Mushfiq has covered pretty much all of South Asia, I'd rather cede time to him. Let me just share some of the stuff from Pakistan. And I'm going to go fairly quickly, partly because both Sania's talk and then Mishail and Omar's comments afterwards covered a fair bit. And so I don't want to repeat stuff. This is stuff I've been doing in partnership with the consortium, very much like Mushfiq's. We've been doing a fair bit of work, much more localized, mostly with the Punjab Health Department since kind of COVID started. And I'll give you different snippets of both that work and other related work, just to give you a snapshot, if you will, perhaps a bit more detail compared to some of the talks on what we've seen so far in COVID. So this graph you've seen, I think Mishail showed it, I assume Sania showed it as well. This is from, by the way, the reason I'm highlighting this is also coming from the Sindh government. And I want to highlight, this part about, there's some really good kind of data being shared in Pakistan. And this is literally on a public website. And if you wanted to, they can give you, it's a whole presentation. I just took one slide from it. What is nice about it is it tells you not just the evolution of the pandemic in Pakistan, but it also kind of overlays that with events like lockdowns. And you can start seeing, like, for instance, you see, there's a hotspot lockdown expansion. And I think Mishail mentioned that Pakistan had done a pretty decent job of sort of smart lockdowns or data-driven lockdowns. This is a good example of that. The minute the lockdown hits, you see a pretty powerful decay. You obviously see rises coming from different waves that are naturally happening. But each time you sort of see mobility measures coming in, kicking in, and sort of having an effect. You can do this more precisely, but lockdowns definitely, just like Mushfiq talked about masks, it's very clear that these lockdowns, at least in transmission, do work. Now they might have an economic cost, and in a Q&A we can talk about that. So that's just to remind us kind of the Pakistani situation. Again, if you remember the graph Mishail showed about Pakistan versus other countries, these heights are flattened tremendously when you compare against many other countries. So, by and large, it's a pretty decent job at containing. Now, what you also see happening is I'm going to show you a bit of results also on mortality and things like that. So you got to have a sense of what's happening in the country. So this is data. I'm going to show you now mixed data. I started with Pakistan overall. I'm going to show you data coming from our own studies in Punjab, sort of that we've done analyzing the government's data, but also doing surveys. The mortality patterns are pretty much similar to what you'd expect in other countries, kind of increasing with age. You can see this in this graph, a bit higher for men than women, but not substantially so. This idea that it's just an elderly male disease, definitely not the case in Pakistan. And also, we do see over time quite a bit of changes in mortality rates. So the average remains around 2-something%, but you can see on this bottom graph kind of over here, you can see that mortality rate does jump up and down. Whether this is coming from different waves or different regions it's hitting, we don't quite know, or different pressures on public infrastructure, but you do see variations kind of in mortality rates as well. Another question which is interesting for us when we look at this data is, what is the kind of spread from the index patient from the first case to subsequent cases? This is kind of an important question that one can ask. And here too, what is interesting in Pakistan is, this kind of spread within family. So Pakistan did a pretty decent job of contact tracing and testing contacts then. And what you see in the data is the vast majority of people actually don't get infected. In fact, only about 2% of your contacts are actually infected. And when we first started this work, we thought this number would be a lot higher than what we're finding. And why this is the case is still somewhat of an interesting question for us, but it's very clear that if we were initially worried in South Asia of dense households with average of 7 people in a household, and that's going to create this massive cluster of infection, that's kind of not what we're getting. And so, in some sense, that is sort of kind of reassuring. Sorry, I skipped one graph in between I wanted to show. This is just positivity and symptomaticity. I never get this right. The fraction of people who are symptomatic. And again, you see a strong age profile in both of these. But I want to come back to this kind of contact effects. What we see, if anything, and again, this was against our prior, we thought younger people would be much more likely to be spreaders. But it turns out, at least in our data, when the index case, the first person infected in a household is a young person, they tend to only affect about 2% of their surrounding individuals, whereas elderly people almost infect twice as many. And this could be also because of viral load differences. We're now beginning to realize that if the younger people are more likely to be asymptomatic, which the previous slide that I quickly showed shows, then it also, even if they're more mobile, it may explain why they're not infecting too many of their kind of contacts. Vaccination rates, again, these numbers have been given to you. Pakistan is now sitting, so I won't repeat these, about 10% fully vaccinated. They've done a pretty decent job in the last couple of months expanding this. Some information over here, again, from our surveys. There are lots of people doing surveys over here now. This is data that we had from the city of Lahore, and you'd expect this to be somewhat perhaps a lot higher vaccination rates than it would be for the rest of the country. So keep that in mind. We find about 20% of people in Lahore are kind of no-vaxxers when we did our surveys. In Punjab, there's another survey that SERP, the research organization that I'm affiliated with, is about 30%. So, there is a bunch of no-vaxxers, but it's not terribly high, at least in these early phases. Hopefully, I think Mushfiq's work and others will get this number down even more. And when you look at what people are saying, I mean, yes, people are worried about side effects. Some extreme views on vaccination may even lead to mortality. But what is funny is when we ask the same people who are saying no, what would it take to incentivize them? And this is all self-reported data. So again, I'm waiting to see kind of the trials that Mushfiq and his team are doing. And I'm very excited about those. But things like simply having free health checkups, a mobile van, just convenience and cost seem, at least on vaccines, to be big movers, even for those people who are initially saying no. And so I'm hopeful that there will be some movement, Mushfiq, from your kind of experiments over here as well. Just the success you have in mask wearing, I'm hoping will translate into vaccination as well. One thing I should highlight over here, this is obvious for epi folk, but there is a lot of confusion, and I say this with some amount of caution because maybe scaring people and getting people to is the right thing to do to get people to comply. But the reality is most of the data that we're getting from Pakistan, and I would hazard from other countries on positivity rates, is a massive overestimate for a very simple reason. And you can kind of see this, and I'll give you two reasons. So this idea of positivity rates versus true prevalence being very different is actually the case in Pakistan. And I'm showing you a couple of graphs just to show this. So this is all data from Punjab, all tests being conducted by public and private labs. And you'll see a bunch of interesting things over here. First of all, if you look at the top panel over here, this is positivity rate as measured by different labs. And the red are private labs and the blues are public labs. And the size of the circle is how many tests these labs are doing. And you could already see private labs are showing much higher average positivity rates than kind of public labs are. And when you break them down by some of the largest, these three are the largest, these two are the largest private labs, and this is the largest public lab. When you break this down in a time series, because you might say, well, maybe labs are testing people at different times. It's not the case. So the two private labs in the bottom graph are in blue and red. Again, you typically see that private labs tend to, on average, be much higher than public labs. And if you know people's behavior, you may already understand what's going on over there. And I'll show you a graph in a second. What you also see a bit more worrying is we have data on what test kits you're using. And we see big differences in, again, a positivity rate depending on what kits are being used as well. And so there's some protocol differences that one should be worried about. And so one kind of big takeaway is it's really critical. And again, any ID or epi person will tell you this, having standardized protocols for testing is going to be really critical. But what is even more striking to us, and again, these are things one can correct, is, so I'm showing you, I'm breaking the same data I showed you in Pakistan on the time series, now just for Punjab, but I'm breaking it by 4 different types of samples. So the solid red line is the original data I showed you on prevalence rate, smoothed out in Pakistan over the kind of period till the end of June. But what is interesting is if you look at the light blue and the dotted blue samples, these are samples from both public and private labs for individuals who self-report to be tested. Again, not surprising, if you're showing up to be tested, you may suspect you have a higher probability of being infected. And so we'd expect that sample not to be a true prevalence measure in the population, but really this measure on people who are more likely to be COVID infected. What am I trying to say? It's kind of obvious. You really need to be doing systematic. I know we talked a lot about Pakistan doing a pretty good job with data. And I agree with that. I think the one place, though, where Pakistan, including many countries, have fallen tremendously short is we don't have good prevalence measures of COVID. And so when you think of lockdowns and the cost, I'm an economist, so I'm going to speak from that perspective. Have we done too much lockdowns? Have we been too extreme in controlling? And for that, you need a much better and much more precise measure of prevalence, not just self-reported people showing up to be tested, not just that measure. And when you look at data sources which are closer to random, and that's kind of this black line and the dashed kind of red line, those numbers are a lot lower. In fact, we've managed to do some purely randomized testing in Lahore. And just to give you a sense of the scale differences, in a period where infection rates were actually somewhat low, in this data that we're doing, the kind of admin data that most countries report, we were getting about 2% or 1.7% positivity rates. But in our random testing, we were getting something which was about 1/10 of that. I'm not saying the true rate is 1/10 of what you're observing in these samples, but I am saying that it is really critical if you want to have lockdown measures or abatement measures. And this would apply for vaccination rates as well. You need to really do true kind of randomized sampling to get at these things, because this not doing so can make an order of magnitude difference in your estimates, and hence lead to potentially very misleading or costly policy responses. Let me just end with one slide. This is a separate study that SERP has been doing, kind of a panel. I know Mushfiq and others have done some really nice studies over here as well, where you're tracking a panel of individuals to see what is the broader socioeconomic impact, not just of COVID, but of the abatement measures around COVID. And what you can see is these surveys are basically over about a year's period, or actually this is about 6 months interval. So each of these graphs is about 3 months apart from each other. And you can see across various measures, there is, yes, there's some improvement in terms of, say, people who are unemployed, but there's also a kind of flattening. And so there's a concern that the economic recovery is slower than we'd hoped for. Even things like income loss, yes, the numbers have gone down, but in some places like rural, if anything, they're going up. And so there's some concern that this shock may be progressing in ways which are more unseen on the non-health outcomes. Now, a couple of measures, food security still remains pretty high. A lot of people are unable to pay bills. Sania had mentioned about EHSAS. It is one of the most effective programs to deliver welfare. In fact, 95% of the people who report receiving any kind of government aid in our sample are for the EHSAS program, but only a quarter of those eligible or self-reported eligible are receiving it. So there is clear issues in getting this support to individuals. 20% of individuals report the need to borrow. A quarter of individuals are reporting serious mental health issues. And so, there are these concerns. And against these concerns, and this may be politically, I know Omar mentioned the politics around this as well, expectations are very strong. This is when you ask people what you expect to happen in the next 6 months or 3 months or the next year, people are expecting a massive rebound. And so one interesting question is going to be, as much as we deal with the health crises, I don't think we're making as much headways on the socioeconomic sort of fallout. And people may expect a much stronger recovery against what you're producing. And if that's the case, you can imagine the ramifications of that on governments and popularity of governments and what we would do. So that could be a really interesting thing we could get back to in the discussion. So I'm just going to end with kind of thoughts for Pakistan. Yes, I think there is, Pakistan often is in, we joke in Pakistan, we never have good news to share, especially in international fora. I think there is good news to share. I think Pakistan, by and large, has done a pretty decent job through its measures. We don't see differential mortality rates. Vaccination rates are improving. There are ways to go. There is better need now that we've gotten used to using data a bit. Let's get data right. And not make costly decisions. I'm thrilled that people are using data. I'm slightly concerned that they're using data which is inaccurate and potentially misleading. And so I want to worry a bit about that. And I really think, this is something I'm beginning to do at CID, the center I direct. I really think we collectively need to start looking, maybe this is a bit optimistic beyond COVID, but what I mean beyond COVID is there's going to be long-term lasting effects of what COVID did, both on health outcomes, but also on non-health outcomes. And I would like to start seeing, we talked a bit about collective work in South Asia and kind of across the region, a lot more thought on how are we going to rebuild, and in particular, are there positive lessons from what we've learned, whether it be in education or health or small firms that could be deployed in a sustainable way to put us on a faster growth trajectory. So the narrative shouldn't just be about how many years of growth or how many decades of growth have we lost or development have we lost, but more about what are the lessons we can take which can put us on a faster growth trajectory, a better growth trajectory, so that not only do we recover, but we overtake. So let me just stop kind of on that maybe a naively optimistic view, but that's kind of where at least my mind is at these days. Thank you.
Thank you, Asim. I have to say that, when I at Harvard, I used to teach the politics of India, and they used to always say, well, why don't you teach the politics of South Asia? And I used to say, I don't know enough about Pakistan and Nepal and Bangladesh and Sri Lanka, and I feel I should. But I have to say, like today, I feel like the most on top of any issue I ever had in Pakistan, like between the kind of COVID lunch panel and, the responses of Mashail and now Asim's work, as well as, of course, Mushfiq's, I really kind of feel I have such a kind of a deep, good grasp of what's happening in Pakistan on COVID. So, I kind of feel I could teach a COVID in South Asia class, even though I could still not teach a politics in South Asia class. But to kind of round it out, I am going to turn to Dr. Ramu Karel. to take us through some of what's happening in Nepal.
All right, let me see if I can get the presentation open. Okay, you can see that, right? All right, thank you so much. And it's a pleasure to be here, and Ashim and Mushfiq. So it's such a pleasure to be in a panel with you and to hear all the amazing work that has been going on. I get the honor to be the last talk of the day. So, and in the 15-20 minutes, what I'll do is I'll just give you a sense of what it's been like in Nepal. A lot of this comes from my own experiences when I was there working during the second wave, as well as some of the work that we've done. All right, so we'll discuss the Nepal's context and its COVID profile. I'll talk about a study we did with the female community health volunteers in Nepal, and we'll sort of end with the challenges and way forward for the country. So as you know, Nepal is between two giants with an open border that's 1,100 miles with India. It has a population of about 30 million. Most of them are young, with a median age of 25, and most of them live in rural areas, around 80%. Nepal has seen more than 2 decades of political instability since the Maoist revolution. Finally, in 2015, there was a constitution ratified, but a major earthquake happened, and there was a lockdown by India on sort of export. And since then, we've had about 5 major changes in leadership, and recent one being 2 months ago in the height of the pandemic. So quite unstable politically. And we have a high young people that leave the country at a young age to Gulf countries, as well as to India for economic opportunities. I'm one of the young persons that's in America, so I'll give you an example. All right, how does the health system look like in the country? The health system has decentralized recently, but it's quite young. Since 2017, we've gone through a process of giving the powers to the local and provincial government, so they don't really need to report to the central government. But our infrastructure is quite weak. As of a few months ago, there were only 1,200 ICU beds, 500 ventilators, and our workforce really leaves the country quite much. We have about 0.7 physicians per 1,000 people in the country. But the access for rural area is quite difficult, especially when it comes to monsoon season in the country. And the health system is quite Kathmandu-centric as well. So a majority have a really hard time accessing tertiary level care. So let's look at what COVID-19 looks like in the country. You can look at this graph or the epi curve, and you can just overlap it with the India's curve, and it will just be a few weeks probably behind, but it's exactly the same. It follows exactly what India has done in the case rise, and you can see the massive rise during April, May, and June recently. The incidence per 100,000 people in Nepal is the worst compared to its neighboring countries, worse than India, worse than Pakistan and Bangladesh as well. And most infected are young people, but that's not a surprise because the country is filled with young people. And if you look at where the burden is high, you see 2 really major areas. One is the 3 districts in the Kathmandu Valley, which is the port of entry to the country by air. And the second are all the districts that are sharing open borders with India. And of course, we've seen images like this, too many images like this over the last 4 or 5 months from South Asia. During this time when second wave was sort of creeping up, I happened to be in the country. I was actually going there to get married, but that didn't happen. And while the world sort of lens was focused on the crisis in India, Nepal actually surpassed India as the highest reproductive rate as well as highest per capita for cases in the world in May. And then we saw really the weak system completely collapse. This is just a scene from one of the hospitals I had visited. It's the infectious disease hospital in Kathmandu. And you can just see, I mean, people were outside waiting for oxygen, no beds. And this was the scene at almost all hospitals that you can imagine in Kathmandu. And so during the second wave, we really saw some challenges highlight. And some of the things that that we noticed are this big gap in healthcare infrastructure and really oxygen supply. During the last 3-4 months that we got from the first wave to the second wave, there was no effort that was made to build oxygen plants and procure oxygen supply. And soon people were quite literally suffocating. I personally would get phone calls probably every 10 minutes asking for a ventilator, ICU beds, just as a doctor to help as much as you can. And even as a real doctor, you can't really do anything if you don't have the supply. The picture on the right here is actually we were able to procure like 300 oxygen cylinders from China, and that was done by our team. So that was great, but it took so long to get there that a lot of the cylinders actually got there after we actually needed them. There was deficiency in things like paracetamol, as well as other ICU equipments. The second problem that we saw was the rural people were really suffering. The helicopter EMS is not widely available, and especially with the rainy season, it's really, really hard for people to get transported to cities like Kathmandu. And I know relatives, people that would call from rural areas, and there was no way to bring them to Kathmandu or other places to give them access to care. We also saw a lot of coordination challenges. Nepal is a country, like many other South Asian countries, that has a lot of NGOs that work during the crisis, as well as it's a new federal government, and the municipalities don't really have their role honed in. They've never gone through a crisis like this before. So, for example, in the Kathmandu municipality, which is the largest in the country, the mayor didn't know whose role it really was when it came to building isolation center, right? Is it the central government that needs to do it? I was directly advising the mayor and also working with other people in the central government. And really, I mean, we struggled to build this isolation center by 2-3 weeks because the role was not quite well defined. And there was also problems within the government bodies. There was a new sort of crisis management committee that was established for COVID, and the role between the Ministry of Health versus that was also not clear. So there was a lot of coordination challenges that we faced, and then finally, data availability. I think the Ministry of Health is doing a better job now. Just we saw with Pakistan in making data more available, but data collection kind of stops at district levels. And we really need to penetrate the rural levels. And we saw from the Pakistan experience, I think this was a lunch panel talk where the FCHVs and community health workers are quite mobilized there. And that was not being done in the country. So that actually leads me to the next point I want to make is regarding the female community health volunteers in the country. Our team decided to do a rapid survey just because we had no rural data regarding testing, regarding vaccines, what's really happening there. We decided to conduct a rapid survey. And as you know, FCHVs are the last mile of health information when it comes to getting it from our health system to the community. And they have been instrumental for decades in vaccine programs, maternal health programs, child health interventions. So what we ended up doing was we surveyed 593 FCHVs across all 7 provinces, and that included 222 rural municipalities and 39 districts. And we asked them 3-part questions. And I just want to share a few key findings that we had from the survey. So one was we had this complaint, oh, people we're just not testing. We're just not testing in the rural areas. So why was that? Do people want to get tested? And 86% of the FCHVs said the communities that they cover, they do want to know if they have COVID. They do want to get tested. So what's the problem? How far are the testing sites from from the communities. You can see here, more than 40% said they had to travel 2 hours. Now, I can tell you as a practicing doctor that if you have COVID symptoms, traveling and most by walking for 2 hours, I wouldn't do it. So I don't expect people in rural areas to do it either. So that was the major issue. And 63% had said they needed to go at least 1 hour. So that's quite far, especially in a country that's mountainous with hills and all that. How about vaccine? We know that developing countries are more accepting of vaccines. We have many studies that show that. And in Nepal context also, we got 91% of the FCHVs said that their communities are asking when they can be vaccinated. They want to get vaccinated, right? And even the ones that said, there's a very few numbers that said they do not want to get vaccinated. Most of them are like they have questions or they're indifferent and they don't know. So that number is probably even higher. Now, because they are the last mile of health information, we also asked them about their own health information and how much they know. And one of the gaps here you can see is who shouldn't receive vaccines, right? And in number 1 and number 2, you see pregnant women and lactating mothers. And we know obviously this is not true. They can get vaccines. But there's a lot of other here, hypertensive patient, diabetic patients, patients with heart disease. These are all people who can receive vaccines. So we see that there's a lot of gaps as far as teaching these community workers on what the facts are, because ultimately when we do get the vaccines, they will be the ones hopefully convincing their communities. And another question we'd asked was what directions they're getting from health post to do in their communities. And they are getting directions about masks and hand hygiene, but they're lacking in a lot of other things like how to isolate at home, how to make an ORS solution at home, right? These are things that we can really advance if we expand this community-based program, and teaching could really penetrate rural part of Nepal. And again, this just reinforces regarding training and preparing them. 89% had said that they had not received any formal training. So, going forward, I think maybe this is one of the things we can take from today is learning from each other and collaborating with each other. I was fascinated to learn the high use of community workers in Pakistan earlier. And I think this is something that we have advised our government to do as well. I don't see a different way to really penetrate our rural areas in Nepal. But one thing that I think I practice, I work at the Miriam Hospital and the Rhode Island Hospital here, and every day I get so disappointed because I have people who come in who don't want to get vaccinated. I spend a lot of time, explain to them why you should get vaccinated. And now I am actually against getting a booster shot because I need people in Nepal, people in areas that really want to get vaccinated to get their first vaccine before I get my booster, or that we're wasting vaccines here every day. So I think we have ethical grounds to really send vaccines to countries like Nepal. That's the sort of lesson I take from asking people in the community if they want to get vaccinated. Now, Nepal has many other challenges during COVID-19. One of the main ones that we saw initially was return of the migrant workers. And with the instability at the central level, that was one of the main reasons for community transmission early on, our mismanagement of quarantine center, unable to really manage the influx. Again, monsoon flooding is a challenge every year in the country, and that has been the case last year. And this year, we have seen direct correlation of cases rising in areas that have bad flooding. And of course, we have Dasai and Tihar that's coming up and the festival season. So that's likely going to be a challenge. Just a few thoughts from my end are using the FCHV network, I think would be very beneficial for the country. We really need to work on equipping the health infrastructure. When India was going through the crisis, I mean, we're just left because, India couldn't send stuff. So the country really needs to work on getting plants, especially oxygen plants built. And then of course, vaccines. I want to take the next probably 2-3 minutes and just share with you guys some pictures and some of the work that we did there. As I mentioned, I was in Nepal to get married and also to do some emergency medicine work. But when we got there, the crisis was so bad that all the work we're planning sort of changed. I run a nonprofit in the country for the last 10 years called HAPSA, and we've been working on earthquake relief a lot. But with the rise of COVID, we decided to do a program that would help lower the strain on the health system by keeping as many people at home as possible. We know that 80% of people can generally be treated at home. So we started a home isolation kit project, which pretty much had everything you need to be at home. It had a pulse oximeter, it had medications, mask, soap, and we had instruction there, and we had a hotline phone number that they could call to ask for directions. And we had also put a QR code with a video in there that I had recorded. So I was very excited to hear about Mushfiq's the mass distribution program. We kind of did this at a smaller level, but so far we've had 27 municipalities that have been served, and this is an ongoing and active project. And I'm happy to share the link with you all later if you're interested. When the flood season started recently, we added water purifier to them. We added more masks as well as more soaps in the kits just to make it more useful for the flood victims. While I was there, I worked a lot with the isolation centers setting up, as well as advising municipalities across the country. And I was lucky to have that experience in Rhode Island. I worked extensively at the field hospital here, which really helped me assist some of those projects in Nepal. On the top right is actually one of the first. He's the mayor of Dhangadi, which is in the border of India, and he is the first person who was like, you know what, these isolation kits are really helping our people, and we started with him, and that's how we expanded. The person on the bottom right is the former Minister of Health who are advising, and these are just some pictures of training at isolation centers. And final slide I just want to end with is this is from one of the virtual training that I had conducted on just helping mid-level providers manage COVID-19. This was about 3 hours training. And we had asked before the training if they feel comfortable taking care of basic COVID-19 patients. And 61.9% had said no. But after the training, 94% had said yes. I know I don't know the long term of this, but it was good to know that they were getting some knowledge to be able to manage COVID-19 patients. With that said, I would like to end my talk. Thank you so much for listening. This was a meeting in Patan Darbar Square if you ever get to go to Kathmandu. Thank you so much.
So I trust that our virtual panel, yes, has magically come back on again. So I just want to say just really how much I have learned really through the day, but especially in the last hour. And also not just learned, but been inspired by. I mean, some of these interventions, almost all of them that you've spoken about are really inspiring and kind of really, I think, speak to also just how a lot of us have pivoted, you guys more than I think others, to really make a difference. And so we have about 15-20 minutes for discussion. And because we had the luxury of being the last panel for the day, I thought it might be nice to kind of, in a way, weave together some of the themes that have also come up earlier in the day. And so I had just like a kind of overall kind of comment question for the panel, and also really for all of us, and then some specific questions. But maybe I'll just set up the overall question, and then we also have some questions from our virtual audience, including some in South Asia who are miraculously still awake. So, to me, it's just super interesting because it seems as if like through the day today, so Ashu and Ashish put together this entire day, and the kind of motivation was trying to understand variation. and variation across countries. And I think Mushfiq in this panel kind of set this incredible, unexpected comparative stage by going far beyond his mandate and giving us this comparative picture of a number of South Asian countries. And it seems to me as if, like, if we think of this day and of Mushfiq setting us off on this comparative stage, it seems from what Asim said, also from what we heard from the plenary panel and Michelle and others' comments on Pakistan, that it almost seems to be that, okay, so Pakistan, a rare case, as Asim said, of good news. Things seem to have gone relatively well. They seem to be joined, if you go back to Malia Ahmed's presentation in the first panel that I moderated, by Bangladesh. So Pakistan, Bangladesh seem to be doing not too badly, both in terms of their control of COVID, but also in terms of vaccination. And then we have Sri Lanka somewhere in between, and then we have the disaster that was India, and that was Barkha Dutt's kind of very powerful, poignant presentation this morning, and probably up there also with Nepal, right, with Ramu's presentation. And so Patrick Heller in the panel before this really opened up this idea of comparisons within India, trying to understand why is it that different states in India have had such different sub-national responses, which is obviously a question close to my heart. But I almost feel as if we kind of put together the day's presentations, it almost kind of gives us this comparative picture in which, when we talk about questions of state capacity, Pakistan and Bangladesh would not be our predictions for the states that have come out relatively better in terms of COVID control and vaccination rates. And yet, they have. So I know that there's, state capacity is, of course, about state society links, and that's where civil society, embeddedness, a lot of the interventions that you're doing involve civil society. They all factor into that. But I was just wondering if I could, begin with this question of, how exactly do we understand these variations when they're not exactly squaring with our expectations of state capacity and state society relations in these countries? So, and can we think of something that maybe brings Pakistan and Bangladesh together and distinguishes them, in this case, from Nepal and India? And again, I'm not exactly sure where to put Sri Lanka, but it's probably right there in the middle. So I have that question, but maybe in the interest of time, would you be okay collecting a few questions? Great. Yeah. Do you want to do those? No, please, you go first while I just look at these online questions.
So I have a question for Mushfiq. Oh, sorry. I have a question for Mushfiq. Can you hear me? So I was wondering if you could give us a little bit of detail on what the outcome collection looked like at the second stage. So my understanding is that you didn't take a random sample of blood from the participants. So it was conditional on self-reporting of COVID symptoms. So do you think that the self-reporting of COVID symptoms might be affected by treatment status? Do you check for that? And do you think the fact that, it wasn't random testing of blood, do you think that can bias your results in any way?
I had actually one follow-up myself, if that's okay. One of the questions I had, because I read your RCT, was a huge fan of the study, is one of these questions about external validity, which is, how much do you think we can externalize the results from this trial, which was obviously wonderful in its context, but to other South Asian nations and even to the US, which it seems like many people are taking this study and running with these results. I was wondering what your thoughts were on that as well.
And actually, Mushfiq, if you still have the appetite, we have a couple of questions from the virtual audience actually directed for you. One of them says, great research, Dr. Mubarak. Did you have two different group of people and researchers in each village? One group of people were collecting the data on whether the villagers were wearing masks, and the other second group were distributing and promoting masks, or was this the same group? And another question, Mushfiq, is that out of all the measures that you took, what was the most effective of all to make people mask compliant? Was it a financial incentive or a local national role model wearing a mask, or was it the repeated reminder? And if it was a repeated reminder, Was it a local person or by digital media, text, SMS? So a kind of overarching question from me to kind of set the stage. And then Mushfiq, you have a bunch of very specific questions, but maybe I'll turn it over to you, Mushfiq, first. I'll see if there are any more questions from the audience and then turn it back to Asim and to Ramu.
Okay, thank you, everybody. Those are excellent questions. So I'll start with the very specific ones and then come back to the big picture point you raised. So on on self-reporting of symptoms, the way to think about it is that if we could take random sample of blood collection, actually we did, so we'll have some results to report soon. But the reason why we are we chose our primary outcome to be symptomatic seroprevalence, right? So first, identify people who are symptomatic and then do seropositivity surveys. And then we also prioritize those, like to test those blood samples first. The reason is that to be statistically powered to track asymptomatic infection would have required tens of thousands more blood samples, right? The reason why we can track symptomatic seropositivity more easily is that, once people are symptomatic, then those tests are, of course, more likely to come back positive, right? And therefore, just with the trial budget of less than $3 million, we're able to actually get that done, whereas you would require several $1 million more to do asymptomatic seropositivity. So I'll just say that those results are coming, right? And now, after seeing these results, some other funders have decided to invest more. So we're actually designing a new trial to do asymptomatic transmission as well. And so I've also thought through the excellent question about, is there possibility of some kind of self-reporting bias, right? So if there is, it would have to take a very specific and strange form here, which is that somehow you'd have to say that with surgical masks, right, people were more likely to sort of, bias their responses towards, with cloth masks, bias their responses towards saying that they were still symptomatic, whereas with surgical masks that went away, right? It would, so it's, of course, it's anything is possible, but the patterns of the data, and especially given the asymmetry in results between surgical and cloth masks, suggests that it's an unlikely story. Okay? And then the question about, what are the interventions that worked best? So a lot of those other things, text message reminders and incentives, etc., actually didn't do much at all, right? So if I had to pick one thing that I felt was like through focus groups and sort of theorizing myself and then running that intervention, if I had to pick one thing, it's what we call the reinforcement component, which is going and stopping people, intercepting them, and politely saying, "Can you please put your mask on? Why didn't you bring it?" So that has like some informal social shaming, some mild social shaming going on, right? And it appears that people just like to avoid being harassed like that, right? So once we added the reinforcement component, that's when people were like, okay, I better just like take my mask because I don't want to have this stupid conversation where I'm stopped and somebody's like trying to shame me into wearing something. And then I'm trying to remember the other questions. Yeah, okay. So in case somebody can remind me, but I'll just say, on the big picture question of what's happening in Pakistan, Bangladesh, and other countries, right? I think, like people like Asim and others, like talented people who understand data and how to interpret data. So during this COVID period, I did notice that both in Pakistan, Bangladesh, the countries and Nepal, countries where I worked, and I saw some variation in this, that there, it created opportunities for stronger and closer links between government decision makers and researchers, right? Researchers both based abroad in the diaspora, but also locally, right? And I think those, that really helped, right, in helping people become more evidence-based in their policy responses. And I hope that that's some of the connections that will persist beyond this pandemic, that will allow us to do more policy sort of relevant work on the research side, as well as for the policymakers to use evidence and take it much more seriously. And if I remember the other questions, I'll keep thinking. I will type up some response in the chat.
I think maybe Mushfiq, were you talking about the question about, I think you answered the question about which was the most effective, right, of
Yeah.
all. And then the other
So
one was
external
really just,
validity.
was about, a logistical question about, did you have two different groups of people, researchers?
Okay, I'll take 1 minute. So yes, so we were trying to be careful on that. So there's one organization called Green Voice that did the implementation, and a separate organization called Innovations for Poverty Action that collected the data, right? And when the data was collected, we were also being careful that it wasn't done in an obvious way so that people don't put their mask on because they feel like they're being monitored. So these are plainclothes people who are like at the mosque for an hour, right? Standing by the street side for an hour, or going to the tea stall for an hour with a smartphone app, just recording what's going on, right? So we were trying to be careful to not bias observation in any way, right? And then there was a really good question about external validity as well. So the way to think about it is that, I don't think it's a good idea for any of us to say, oh, look, this worked in rural Bangladesh, and therefore we should declare victory and just implement this everywhere. So when we took the model to Lahore, we spent a lot of time thinking carefully about what adaptation is needed. And in fact, like taking, or even to urban Bangladesh, when we did the project in Dhaka and Chittagong, and I would say doing the project in rural Pakistan is actually more similar to doing it to rural Bangladesh than it is to just do it in Dhaka and Chittagong, because the nature of social norm forming, et cetera, is very different, right? So the way for us to be responsible about scale up is to not declare victory after one trial, but to think carefully about, okay, the underlying concept here is that social shaming was important, right? In a rural area, but social norm formation and who you're shamed by in a city is very different. So in a city, we focus much more on like the transport hubs, the transit hubs, where people are gathering close together. And in the picture I showed you, the mosque played a large role in rural Bangladesh. Obviously, in Nepal and India, it won't, right? So the two things we're doing is making sensible adaptations, but second thing is continuing to collect data and continuing to do the monitoring so that we can course correct as we go forward. And now about external validity to the US, there's two stages to this. So one is how to get people to wear masks, which I think has the social science part of it, where you have to be very careful about transporting your ideas, right? But the second part of it, the epidemiological part, which is how the virus is interacting with the human body, I feel like there's a lot more external validity in that part of the study.
Yeah, I kept thinking this kind of like what I feel like doing all the time, the mild social shaming of people being like, please, can you put your mask on? And I just thought, yeah, good luck to me for doing that here in the US. But we're going to Asim and Ramu, if maybe just like 2 or 3 minutes. Actually, before that, any questions from any more questions?
Yeah, can I?
Yes, absolutely, Ashu. Sorry.
Yeah. So we've had a very stimulating day. And let's just try go towards the causal explanation. Not that it can be done so quickly, but simply take a path towards that. So, and this is the bigger question that Prerna asked. What explains, or at least tentatively, before we do the real causal analysis, what explains why Bangladesh and Pakistan have done so much better than India and Nepal? And incidentally, Prerna, I didn't read the Sri Lanka explanation as middling. Sri Lanka has vaccinated 40% of its population, which is the highest in South Asia. So, but anyway, Nepal has the lowest vaccination rate, something like 2%, if I recall, or 2 or 3%. But India, Pakistan, and Bangladesh are around 10%, plus minus. But the outcomes are very different. And in any case, vaccines will, if you want to use them as a predictor, and I think they are, then they'll be confined to the second stage, not to the first wave, because there were no vaccines available at that time in the first wave. But anyway, the point is that whether you do the first wave or the second wave, for India, Pakistan, and Bangladesh, vaccination cannot be the explanation for divergent outcomes, because they all 10%, 11%, 12%, and the difference in outcome is very large, right? So is your sense that of the other factors, masking, social distancing, lockdowns, that do you and Mushfiq well you only did masking, maybe you want to say something about masking on in these three countries, Bangladesh, India, and Pakistan, whether masking, lockdowns, social distancing were a bigger variable, explanatory variables, than vaccines, because on vaccination rates you're not getting a very significant difference, except in Sri Lanka and Nepal, which are on two extremes. Nepal is, I think, 3%, Sri Lanka is 40%.
Thank you, Ashu, for kind of nuancing that question and for your insights. So maybe just because we are kind of rapidly running out of time and approaching the time when those of us in person can be unleashed outside to have a drink, is maybe Asim, if you could just reflect for a few minutes.
Great, thanks. Prerna, that was an excellent question. It's something I feel like we should be writing a tale of two Punjabs and a tale of two Bengals. Precisely. I mean, there's lots of reasons to write that independent of COVID, but for sure, COVID has made it very clear. I want to caution a bit, before we go, I'm an empiricist. And so the first caution is we have very few degrees of freedom over here. We have very few data points when we talk about countries. And so it's very easy to draw on what I think will be odd arguments like faith, divided intervention, random luck, a whole bunch of things like that. So I want to highlight one thing which we saw. So Jishnu has been doing a lot of work in Punjab, in Indian Punjab, and he was working, Jishnu Das, there's a Georgetown. And Jishnu and I have been working also in Pakistani Punjab, and we were looking at the data much earlier. Ashu is exactly right. This is all pre-vaccine world. The differences we were seeing were emerging as early as June of 2020, as May and June of 2020. The one thing we did see, and perhaps this is a bit of a downer for those of us looking for deeper state capacity or kind of type things, we were seeing huge amounts of local variation. Even within a city like Lahore, we were seeing variation, which was hard to explain. And I think we tend to forget, and as much as I love my epi friends, I think we tend to forget in these models, there is such a thing as small errors in random errors in measurement or prevalence. And those can have massive effects. Remember, these transmission models are nonlinear. So what you may be thinking is some deep structural explanation, honestly, could just be a bunch of random luck and a few things that you choose to do or didn't do. And you could read into, Saudis after all canceled Hajj and India didn't cancel the Kumbh Mela, but Pakistan did have Bakar-Eid, maybe it was more subdued. And so my honest, I don't want to discourage us from looking at the explanations. My sense is my only two pieces of advice over here are recognize that there's massive amounts of local variation. If there is, then looking for higher level, cross-country, national type explanations are probably not where you should be. If you just do an analysis of variation or decomposition of variation, how will they explain local variation if it's all about country A versus country B? I'm not denying that there are some aspects there. And I do think sometimes decisions which we think were small, or some of these decisions, and I'm just imagining the Hajj committee versus whatever, the Kumbh Mela committee, if there is such a thing, having some debate about should we open or should we not open. And I don't think those were necessarily overwhelmingly yes or no decisions. I think these were marginal decisions. And for me, the big lesson over this is that some of these marginal decisions could have had massive consequences precisely because of the nonlinear nature of the spread. And so the lesson isn't to me, did you get it right or did you get it wrong in that sense? The lesson to me always is, what process of decision-making were you using? And so I would say if we're going to do this analysis or this comparison, it's really to start digging deeper into the decision-making processes. And perhaps some country lucked out and all had good processes. I don't know enough about that as yet. I agree with Mushfiq that in the process that I saw in the countries I'm working in, but that was just as true as Bengal as it was West Bengal and East Bengal and West Punjab and East Punjab, is that a lot of decision makers, and this is the good news to me, rather than us picking why did India fail, and I know there's a lot of concerns about that, The good news is there was a lot more openness to information and data than I've ever seen before. I think Mushfiq is right about that. And not necessarily that they're talking to researchers. Obviously, I'd love it if that was happening as well for self-serving reasons. But I think just the appreciation of information and using information to act, I think was a positive that I saw everywhere. And that's the silver lining I'm taking out of this. And I want to make sure that that silver lining be recognized, even in situations where the outcome may not have been as desirous as we wanted it to be. Because I think there is that important recognition. The other thing I should say is, this I saw in every country, I think it's worth repeating over and over again, the amount of frontline, I don't just mean doctors and nurses, obviously they're frontline, but I mean bureaucrats. I was shocked at how much civil servants, public servants were putting themselves at risk in all of these cases. And I think that's another, again, my prior hadn't quite been that in some of the previous work I'd done. And so I was just really positively buoyed by seeing both the usage of information and decision-making, whatever information was available, and also the willingness to put oneself in harm's way to deliver public service. So maybe again, I'm too optimistic and naive over here.
Thanks, Asim. We're almost running out of time, but I cannot resist this. So, I just have to say, so I'm completely on board with the subnational, that we really need to kind of explore subnational differences because they're stark, and that's what I work on, so that's great. But I feel as if because you've made this kind of pretty frontal attack on my discipline, which is that we shouldn't be looking at like cross-national comparisons, I want to take an example that you gave and maybe just point to why I still think that's important. So Hajj versus Kumbh, right? It wasn't, so Pakistan cancels the Hajj, and Pakistan is technically an Islamic state, right? I mean, India does not just not cancel the Kumbh. It is, so, you asked, is there a Kumbh committee? The BJP supported and endorsed the Kumbh. The Kumbh wasn't even actually supposed to happen this year on the scale that it did. It subsidized train travel to the Kumbh from all different parts of India. Right. So I completely agree. Huge subnational differences, hinterland versus cities, different neighborhoods, different parts of India. That's what Patrick Heller's presentation was. But, the politics of what would lead Pakistan, technically an Islamic state, to cancel the Hajj, and India, a democratic state, to actually go ahead and subsidize and support a Kumbh. Like, to me, that your
I agree. I can see that point. I think you're right. At the end, when we do this analysis decomposition, there will be some part of the variation explained exactly by what you just said. I should say, by the way, it wasn't Pakistan canceling that, it's Saudi.
Oh, right, exactly.
Pakistan just was a bit, but
yeah.
But I do think, look, we've looked at large events. We know, I mean, Ashish is in the audience. We know there's a very nonlinear scaling effect in events as well. And weddings are much smaller. As much as we decry weddings, they're much smaller than something like the Hajj or the Kumbh.
Right.
So you could tell, and I again, it's one data point, but you could spin a story just on the Kumbh decision versus the Hajj decision to explain massive differences. Now, for that, you'd need to look at, across state variation in India and kind of Muslim majority areas in Hindu. You're going to run into some amount of, if mask wearing was contentious for Mushfiq, I think you're going to be ready, Prerna, for a whole bunch of real pushback.
No, I mean, I think just to make, absolutely, I agree with absolutely everything that you said. Ramu, very quickly, did you?
Yeah. Thank you so much. Now, I totally agree with Asim's thought that, I think it'll be a lot of speculating as to what were the difference in these countries at this point. I just don't think we have enough data. But I would like to say, though, when you look at India and Nepal and compare it to the other countries, the sort of the flatness, almost zero cases that we saw from, November to February, I think that was unique to those two countries when you just look at the Pakistan and Bangladesh cases. And during that time, India and Nepal both completely forgot that COVID existed. And then for the second wave, the preparation that was needed was just not there, and it hit as a shock, which maybe one of the reasons of such spread. But one of the first cases in Nepal was a woman that had returned from somewhere foreign. She was positive for COVID. She went to one of the rural areas and kind of spread it all around. We know that even 1 point, because of exponential spread, can continue, sort of make the whole community sick. So it might just be luck that some countries miss those at certain time. But for Nepal specifically, over the last 5-6 years since the earthquake in 2015, we've seen how devastating that has been for countries return back to normal. And we knew that from the earthquake, there was so much support globally, right? Like Nepal was relying on global support. And what this pandemic has, what the second wave has actually done for the country, I think is actually something good. It has actually mobilized people within the country, people, one like myself, but also many young people who are able to, because there was no one left to help. There was no India left to help. There was no China left to help. There was no US help. So I think that's the one positive that has come out of this, and hopefully that continues with the youth and people that are working in the country.
Great. Well, on that positive note, I just want to thank all of you here, our in-person audience, our virtual panelists. Thank you, Mushfiq. Thank you, Asim. Thank you, Ramu. Ramu, if and when you do get married, I hope it's a happy one. Happy birthday to Asim's daughter. And, as we kind of continue kind of unfolding, I don't know what kind of return to normal this is. This is our first hybrid event back at Watson in this room, in which so many of us have seen a far more packed interaction. But I really just want to thank all of you for being here through the day today, to the STAR team of Ashu and Ashish for putting this together, and to Stephanie, Motri, Morok, Grace, John, Alex, who've really risen to the occasion to make today's day such a fruitful and rich one for all of us. So thank you, because this is also the conclusion of the day, and I hope that those of us who are in person can enjoy this beautiful evening outside. Thank you.
Thank you, everyone.
Thank you. Thank you very much. Thank you, Asim. Thank you, Mushfiq.